good evening to all of you. First of all, I would like to thank Dr. Sachin for giving this opportunity. But before I start my talk, I would like to first of all wish our central pillar of hematology at PGI and who has nurtured multiple generations, Dr. Subhash Verma, very happy birthday. Today is Sir's birthday. I'm wishing him a very, very long and a healthy life.
Happy birthday.
Thank you, Uday. Thanks a lot.
Happy birthday, sir.
Thank you.
Okay, so without wasting much time, I'll quickly get on to the management options and about relapsed refractory multiple myeloma. Now, I would like to start from where Dr. Ullas has stopped, that is the hope. So, what ends on hope does not end at all. So, therefore, like we would like in myeloma to shift away from an incurable oblique a non-terminal disease to more of a curable disease over a period of time. As we all understand that as the disease progresses from MGUS or monoclonal gammopathy of unknown significance to myeloma, and as the disease gets relapsed, so patients keep accumulating lots and lots of mutations. Now, this is a graph of the patients with active myeloma. With a frontline therapy, when we expect an average survival of around 20 to 50 months with whatever available options that we have. As the patient relapses, the survival falls down to 14 to 16 months and the disease becomes less sensitive or resistant. And when the patient suffers multiple relapses, then he reaches a stage of relapse refractory stage, wherein the expected survival further falls down to only 6 to 10 months and the disease becomes resistant to all or most of the available options of therapy. So, the relapsed myeloma or relapsed refractory myeloma fare poorly despite of aggressive therapy. So that is the first take-home message that we have to understand. Now, there's a difference between relapse and relapsed refractory myelomas. So to bring back the basics of defining these diseases, relapsed myeloma is the recurrence of disease after prior response, whereas when we call as refractory, we have to understand that it is non-responsive or progressive while on therapy or within 60 days of last treatment in patients who had achieved a minimal response or better on a prior therapy. Now, if we look at the IMWG guidelines, I'm not going to delve into the details of it, but there is a subtle difference between progression, wherein we see that the progression is defined particularly as an increase of 25% from the lowest confirmed responses, or increase in 50% of the PET lesions that we see, or more than 50% increase in the circulating plasma cells. Versus when we talk of relapse, so we talk of clinical relapse or biochemical relapse, which I'm going to develop on in detail. So here, when we talk of clinical relapse, we talk about developing any of the CRAP features or hyperviscosity or patient developing a significant increase in the size of plasmacytomas. And when we talk about relapse from CR, for calculating progression-free survivals, it's much different. And here we are talking about reappearance only of a serum or urine M protein by IFP or electrophoresis, development of more than 5% plasma cells in the mole crowd, or appearance of any other signs of progression. So why I brought up all these things, I will explain you in a case vignette. If we have a 54-year-old male who has IgA lambda disease, received 4 cycles of VRD, attained stringent CR, undergoes transplant, on D plus 2 to 4, he is found to have 6% plasma cells. The SPP is negative, SFLC is negative, and SIF shows a minor IgG kappa band. Remember, the patient initially had a IgA lambda disease. So now, what would you label this patient as? Would you restart the therapy of the patient, or would you consider him as a relapsed disease, and that too particularly because he has, within the first 6 months, within the first 1 year, because he has developed some features, do we call it as an early relapse? So, how do you define in this particular patient? So, if you look at PubMed, if you look at around 445 articles in the last 10 years, you would find that almost 42% people would label this as progression and another 44% would label it as relapse, and the rest, another 10 to 15% would label it either as progression or relapse without trying to differentiate the two. So, if we go by the IMWG criteria, it is neither progression nor relapse, but if we go for IMWG as per the trials, what is used for clinical trial definition of IMWG, it is defined as progression. So people have to understand when we read these trials and when we talk about the patient relapsing on trials and getting better by the second line or the novel agents, they are even trying to include those patients who otherwise would not fit into a clinical relapse or progression. That's why most of these trials would give you a beautiful data as far as the newer agents are concerned. And this goes without saying that the randomized control trials are very different from real world data and both vary. And even the IMWG defines the trial definitions very different from the routine clinical definitions. So the take home message from this particular part of the talk would be progression is not equivalent to relapse. Relapse is not equivalent to relapse refractory. And when you are trying to define progression or relapses, please try to interpret time to progression carefully, understand the progression-free survival or the disease-free survival very carefully, and don't try to interpret or put in the data from the trials directly onto the website, because the trial definitions are very different from the real-world definitions. Now, coming to the types of relapses. If we look at types of myeloma relapses, we have non-aggressive or the aggressive relapses. Biochemical, the non-aggressive can be further classified into biochemical or symptomatic. If we look at the biochemical relapse, this is how it is defined. Progression based on just increase in M protein. No associated symptoms or CRAB features. The non-aggressive symptomatic would be presence of any of the CRAB features or hyperviscosity features or an organ compromise. And when we talk of aggressive relapse, we talk of raised LDH, abnormal cytogenetics, presence of extramedullary disease, very high beta-2 microglobulin, short duration of response or progression while on treatment, and various other features. So these are the patients who have aggressive relapse. Now the next question comes in, how do we evaluate a patient once we think or we label the patient as that he has relapsed? Now, other than the basic evaluation of CBC, RFT, serum calcium, SPPSI, PSFLC, the myeloma panel that we routinely call about, the most important thing is, would you like to do a FISH or not? So that's a highly debatable thing, but personally I would feel that yes, FISH should be offered to a patient if it is not very, like it's not going to add too much of the cost to that therapy. In non-secretory or oligosecretory myelomas, a bone marrow evaluation is strongly recommended, including morphology and FISH on CD138, and imaging, particularly in those patients with extramedullary disease, is important. Now, after we have evaluated these patients, next comes, what are the indications of therapy? Do all patients of relapse, do they require therapy? Now, clinical relapse, development of CRAB symptoms, a rapid rise in paraproteins, that is doubling of M protein, or an increase in absolute levels of M protein of more than 1 gram per deciliter or more than 500 milligram per 24 hours in urine M protein, confirmed by 2 consecutive measurements separated by 2 months apart. This point is something which everybody needs to understand, because this is what the IMWG or the ASH latest guidelines they talk about, that just one report of rise in M protein should not make a physician directly start the therapy until unless the patient has got features of aggressive relapse, which I have just enumerated before. Extramedullary plasmacytomas again are an indication for therapy in patients with relapsed refractory myelomas. Now, all progressions need not be treated, particularly when we talk of biochemical progression, or as per the previous definition, what we spoke about non-aggressive biochemical relapses. These are those patients who can still be observed, because some patients might have a plateau phase of biochemical parameters over a period of time, and these patients, even after down the line, if we look them at 2 years, 3 years, they would have persistently some amount of M protein which is persisting. So just a biochemical relapse should not be taken as an indicator for starting therapy. We need to understand the tempo of the patient by following up regularly or more frequently than what we generally do. So patients with non-aggressive or high-risk disease should be considered for salvage even in the setting of a biochemical relapse. This is the only place where the patients with biochemical relapse should be considered for therapy. Now, so the take-home message for this part of the talk would be, the need of therapy is defined by the presence of symptoms similar to the initial treatment. Not all patients with biochemical relapse or progression need therapy, and aggressiveness of the previous relapse or risk of organ damage or the magnitude of M protein, they all play important decisions. Now, in India, this is a huge, the last point is a huge problem, because the patient for the first part of the therapy will be getting treatment at hospital A, then he goes on relapse to hospital B, and then on relapse to hospital C. So the tempo or the dynamics of the patient, how they tolerate drugs and how the things happen, really becomes very difficult in our Indian case scenarios. Now, once we have decided to treat, how to go ahead with these patients? So the relevant parameters which are important for selection of therapy includes patient-specific criteria, disease-specific criteria, and treatment-specific criteria. Patient-specific criteria: age, toxicity of the previous regimens, nephropathy by the light chains, and mode of administration. If a patient chooses that he will only take oral, or he has no problem with IV, so decides upon what types of drugs that we need to add. Second is disease specific, a good prognosis, that is retreatment with the effective first line schedule is still feasible. Symptomatic or rapidly progressive, we need to switch the drug classes. And if a patient has got high risk cytogenetics, then let's use proteasome inhibitor combination or with daratumumab. The treatment specific basically depends upon the type of side effects that the patient previously had, the duration of response with the previous therapy. So these play an important role in deciding the next line of therapy. Now, selection of therapy would basically depend upon the risk stratification, assessing the eligibility for clinical trials, transplant, and chemotherapy regimen. The second point, clinical trials, I will omit because we do not have really many clinical trials going in the Indian setup. Other than the selinexor trial in the relapsed refractory setting, in India, we have not really come up with huge trials with the novel agents. And it also is important to understand, is it the first relapse, or is the patient has multiple relapse, or he has only extramedullary relapse. Now, if you look at these two patients, I've brought in a 58-year-old female on either side. In the first case scenario, the patient initially had ISS1, FISH was negative, RISS1, but the patient relapsed within 12 months of the first line therapy. Whereas in the second case scenario, the patient had got ISS3, FISH showed translocation 414, RSS3, relapsed after 24 months from the first line therapy with no new cytogenetic abnormalities at the time of relapse. Now, out of these two patients, which would you consider as more risky? So it's just not the initial risk stratification, but the time to relapse actually overtakes the initial risk stratification. So even if a patient has got a good risk in the beginning, but the time to relapse is very short, then those patients are considered to be at high risk irrespective of the initial cytogenetic features. Now, early relapse again is very, very important because the time to relapse within the first 2 years is considered nowadays as a huge important prognostic factor. And in fact, in the recently concluded ASCO and ER, there were multiple papers on the early relapse within first 6 months to 1 year, and they have shown that down the line, over the next few years, these patients really do very bad or very poorly. Now, relapse characteristic modify the risk stratification of a patient. That is what is the take-home message from the previous story. Next, coming upon to the eligibility for the clinical trials, especially important for those patients with high-risk disease, multiple relapse disease, or exposed to most available agents. Now, assessing the eligibility for transplant. Now, this is important in Indian scenario because many patients would not have been given the benefit of the transplant in the upfront setting because of various reasons. Most probably because of the patient-specific reasons rather than the doctor-specific reasons, because many patients would have refused transplant or would not have agreed for the transplant, or the family would not have agreed for the transplant, or because of the financial reasons. So in those patients, we should definitely consider a transplant in the first relapse or in the subsequent relapses whenever the patient agrees to the same. Now, durable benefit of 18 to 24 months post first ASCT. Second ASCT is a viable option with a PFS of around 9 months. Longer or durable remissions and uncomplicated post-transplant course would suggest that the patient would have better outcomes with second transplant. Now, if at all, if there is a provision or if there is the option of availability of the cryo-reserved cells for the same patient from the previous transplant, again, that is a beautiful option by giving bridging chemotherapy, bringing them to some sort of remission, and thereafter giving those cryo-preserved cells can really help. So most of the transplant centers who have got availability or where the finances are not an issue should try to cryopreserve at least half of the harvest for a future transplant, which is a good practice as far as myeloma management of the patients is concerned. Now, coming to the allogenic transplants in myeloma, this is particularly an option for patients who are young, who have high-risk disease and who have relapsed early. So, but the patient needs to be explained about the high TRM and the conflicting data on the efficacy of this particular option. But still, it is definitely an option in young patients vis-a-vis the elderly. Now, there are some special scenarios. So, if you look at this patient, which we already discussed in the previous first case scenario, a 54-year-old male with IgA-kappa disease who was found to have an indistinct band on SIFE with IgG-kappa disease. Now, there is something known as oligoclonal reconstitution or oligoclonal humoral response. So, if a patient particularly shows a light band after the transplant, it need not be relapsed. It could be just an oligoclonal reconstitution seen in up to 37% of the post-transplant patients. These patients need not be intervened as far as the particular SIFE band is concerned. So these are a few of the studies to suggest about the relevance and the prognostic impact of oligoclonal humoral response in patients with myeloma post-ASCT. Now, lastly, selecting a chemotherapy regimen. Now, these are all the options that we have on the various classes of drugs, and it basically the basic concept remains to be that whatever has been tried in the past should be avoided in the future. Two new drugs classes should be tried to be involved, and most importantly, the patient should be on today's date given the benefit of monoclonal antibodies whenever the patient has relapsed. So by understanding this concept, thereafter whatever the person does is good for the patient, and it really does not matter which type of regimen or which choices that people have looked into. Just to quickly summarize about few of the regimens and few of the data on that, for those patients who are not refractory to bortezomib, these are the various trials, Castor, Endeavor, Panorama, and the Eloquent trials, wherein people have used different combination along with Botidex, Dara, Carfil, POM with Botidex, and elotuzumab with Botidex, and all of them have shown a benefit. Now, if you look at not refractory to lenalidomide, those patients who have not been given a benefit of lenalidomide in the past, in those patients, the RD-based regimen can be used in the relapsed refractory settings. And the various trials to show the benefit of the same are the following: Tourmaline, Eloquent, Aspire, and Pollux trials. And in those patients, this is an interesting scenario because nowadays most of us try to give our patients Boti plus Len combination as a first-line therapy. So those patients who are refractory to both these drugs, what are the options? So a POM-based regimen would be a good option in these particular patients, and these are the various data to suggest the same. If a patient is in the previous part, a DARA combination with POMDEX would be an ideal case scenario with the currently available drug options in the Indian scenario. Now, with DARA being nowadays used even as first-line therapy in many centers, or have been given as a drug of choice in the first relapse, so in the subsequent relapses where the patient is refractory to lenalidomide, bortezomib, and daratumumab, then the options come like selinexor or panabinostat, or we give a combination of the previous age-old regimen of BTD-PACE. So these are the drug combinations which can actually benefit in such case scenarios. Now, something new are the hope at the end of the tunnel is that we have got some newer molecules which are coming up. Few of them are BCMA-directed therapies, that is the CAR T-cell transplant. In fact, in India, from the Bombay, there are few groups which are trying to start off with CAR T trials in India. Antibody drug conjugates, again BCMA-directed, and BiTEs, bispecific molecules. The other drugs which are in pipeline are the other CD38 molecules other than the daratumumab, BCL2 inhibitors, venetoclax, and cerebron modulatory drugs, CELMoDs. Also, the melphalan, which was an age-old drug packaged in a new form, that is melphalan, is another option which has actually been talked about a lot in the current ASCO and EA and found to have a great benefit in the relapsed refractory setting. Now, how to sequence these drugs? There are multiple guidelines on this. I've just brought in the various guidelines. There are ASCO guidelines, there are NCCN guidelines, there are ESMO guidelines, IMWG guidelines, ASH guidelines. So you look for a society and they have given guidelines. It all depends upon which guidelines you want to follow, but the basic concepts still remain to be the same. What were the previous drug classes that were given to the patient and try to give a benefit of a monoclonal antibody. So that remains to be the major highlights or the baseline points which needs to be understood. So I finish here and I would like